All right, thank you. So thank you for having me today.
Thank
So I am going to be talking about a study that I did. I actually did a mixed method study on the impact that nurses can have when dealing with individuals with chronic diseases. And I did find in my study that the nurses were very key to effectuating change. So, by way of background, here in the United States, this is a commonly known thing that you see it a fair amount in the literature that we have a very expensive healthcare system. We tend to pay a lot for services, and I think we could do much better at coordinating care. Um, and some of the biggest costs go towards people who have chronic conditions, and they do consume a higher percentage of our healthcare expenses. Individuals with chronic diseases tend to have more ER visits in our country, and they tend to have more hospitalizations. And of course, that's very costly care. The other fact we found very interesting is that there's over 1 billion primary care visits annually here in the States. And I think if there's a way to better organize our primary care and the way we construct our business, I think it can make a big difference. And I think health homes can be the answer for that. We have good access to care in our country. So one thing that we did, and I do live in the state of Michigan, is that with something called an Affordable Care Act, back when President Obama was our president, he passed some major sweeping legislation, and one of them was the Affordable Care Act, which allowed us in Medicaid to start health homes. And basically, the health homes are for people that are 18 years of age of older, have a behavioral health diagnosis or disease, and have a certain physical health diagnosis or disease. And these were all in our state, our federal law in terms of who could be in this health home. But the big thing is to organize and to integrate when somebody has both mental health issues and physical health issues. And so we launched this health home a few years ago. And of course, this is what I did my dissertation on. So the general, we called it My Care Team. The general model design is it's at the primary care practice, and it really focuses on patient-centered care and to look at all the things that are happening with the patient. And it's more also a team-based care because you not only need the nurse, but you need the doctor, social worker. For some people, you may need other disciplines, but the nurse is kind of the main person that keeps it all together and keeps it focused. And then also making sure that we have behavioral health integration for those that have issues. And the last bullet also refers to the role of CHWs, which are community health workers. They're a non-licensed individual, but they help with addressing social determinants of health, like helping people get rides just to go see their doctor, or if they're having trouble getting their prescriptions, to help them set those things up as well. For some people, it was also access to food. We discovered a lot of different things when we did our analysis for doing our health home. Core services is really comprehensive care management, just dealing with all the little and the big things that can help people have a better outcome. Care coordination, health promotion, you can read the rest of it on the slide, but just the kind of supports. In the United States, we're very much kind of like a fee-for-service type entity where somebody goes in and sees their doctor and they have a lab test, they bill for codes. But this part with doing the care coordination is something that's actually been up and coming. But with this My Care team, it was much more intensive. So the My Care team, the group composition is a health homes coordinator, a nurse care manager, which again is right at the center, primary care provider. We needed a behavioral health provider, a CHW, and other supports and administration staff. So the purpose of our study was to identify what the nurse's role or their perception of their role in this health home in terms of making differences with patient health care management. What do they think that they did, and what do they think made a difference with people's health care? So I did a qualitative sample. I did a qualitative and quantitative. And what I did is I did individuals and I did focus groups. So I actually had a focus group where I could sit down with 11 nurses who were the nurse care coordinators of the health home. There were 10 health homes. And so we were able to sit down with a nurse, at least from every one of the health homes. So I did a focus group, which was really interesting to hear the nurses kind of talk to each other as to what they did and what worked. And then I also conducted 7 individual nurse interviews because I wanted to have a larger population. And, I could say that I had saturation of information actually pretty quickly, that a lot of them were seeing the same things, and a lot of them were following similar courses um, of helping individuals and making a difference. And my qualitative, the nursing interviews lasted for about a 12-week time period. For the quantitative sample, this is what I looked at for individuals who were in the health home. And I had an intervention group and I had a comparison group. So I knew who was eligible for the health home and decided not to enroll. And then I compared them to people that were in. And actually, there were sicker people that were quote unquote sicker, actually were in our health home. And I have a slide that shows all that. I needed a sample of 514 total, which was 257 per group. I ended up using a sample size much larger than that. It was 874, which is 437 per group. The main reason I did that was because I could get the data. All my information is from paid claims data. And I said, if I can get it, let's have a larger sample. It could tell a better story. So the qualitative analysis, just as a real quick overview, I did a content analysis and I identified common themes. I recorded and transcribed the interview so I could go back and make sure that I really understood exactly what they were saying. For the quantitative, I used SPSS software. You could see the different types of statistical analysis that I did. So with the qualitative analysis, I found 6 themes in terms of what the nurse felt that they did and what their role was with helping to move the needle, so to speak, to make a difference. And the first one was establishing trust and building relationships. Many of the nurses had said that when people come in and they have all these chronic conditions going on, a lot of times they aren't telling the doctor everything. And with the nurses, they said, once we sat down and talked to them, this model allowed the nurses to sit down and talk to people for a while, 30 minutes or even maybe more, once a month, just to get to know them. And once they started letting down their guard and trusting the nurses, the people told them so much more of what was going on. And that's what the nurses helped to deal with. And a couple of really interesting quotes is, I like the second one that says, we try to understand where people are coming from and the difficulties they face, because some of the issues that they were facing weren't really truly medical in nature. Some people just didn't have access to food. And once they got that corrected, it made a big difference in managing their diabetes or whatever the case may be. Listening to the patient. That's kind of an oldie but a goodie, and I love the first quote that says, if we listen, we can hear everything that is going on, then we can move forward to help them manage their care. As nurses, we think we have the answers, and we do. When we see cases and we see issues, we're thinking, well, we know how to fix this. But with this, the nurses said, I'm going to just sit back and listen to everything that's going on and what was most important to the patient. And they found that sometimes it was things that there are other things that the patient needed to have fixed before they could get to the things that the nurses felt were important. Like, again, if they had high blood pressure, or if their blood sugars were off, maybe they needed to fix something else first. Patient engagement and goal setting. Here they had to, again, work on what was important for the patient. And one thing I thought was really interesting in the second quote is that keeping the goals obtainable. They don't want to be set up for failure. We may look at a case and say, okay, they need to do A, B, and C, but maybe that's just too much for somebody. If they're going to make a change and effectuate change, sometimes it had to be something very small, like just coming to each of the doctor's appointments. And once they did that, the nurses really praised them and said, good job, keep coming in. And then they could set the bar higher and have the goals be a little bit more higher, so to speak, to really make a change. The next one was direct access and contact with a nurse. People loved being in this model, and when they had a question, they could call the office and just talk to the nurse directly. It was amazing how often we heard that. And, they said people do call us. They, sometimes they don't know what to do. When people don't know what to do, they'll just go to the ER to get it taken care of. But they liked the fact they could talk to a nurse and someone that knew them. Addressing social determinants of health, that was huge. There were so many things going on with individuals. And, we had a situation where somebody kept going to the ER all the time, the emergency room here in the States, because they didn't have access to food. And they knew that if they went to the ER, they could get a sandwich. That's why they were going. And, before we developed this health home model, I thought people don't really do that anymore. They can go to other places, but it actually happened. There were people that had their power shut off, and so they couldn't, do a number of things. They had to do dressing changes, and their wounds kept getting infected. And come to find out, they didn't have a source of power or water. So it was amazing finding these things out behind the scenes and being able to help people. And people are proud. They don't always want to admit that they're struggling. Education, people need a lot of teaching, just lots going on with medicine, and to make sure that they're up to speed. So I want to show you the slide on demographics. Now I'm going to switch to the quantitative piece. So you can see that our intervention and our comparison group, that the average age, we had an older population, and then we had something called risk score, which is down towards the bottom. And the risk score is just if you have more diagnoses and there's more severity, your risk score will go up. And I actually, in these two instances, our intervention group was quote unquote a sicker population. Their risk scores were higher, and they actually were a few years older. So emergency room visits, we measured these about a year after the health home started because we knew these people were going to the ER a lot. And we did find that actually the emergency rates did go down in our intervention group. And even within, it went down during the year worth of time. So it showed that there was this movement from going to the emergency room all the time back to the primary care. And, the nurses' comments, I kind of chuckled doing this research because I asked the nurses what was going to happen before I actually pulled the data. And it was funny because the nurses predicted everything accurately. They said, you know what? When we become the go-to person, they're not going to go to the ER. And they said, I think you're going to find your emergency rates are going down because they're calling us now instead of going directly to the ER. But they said there are people that are still going to go, and you just got to change that that's like a cultural shift in terms of getting them to go back into the doctor's office. But it was very interesting how well nurses really know the patients. And again, if they stop and just listen, they even got to know them better with this model, because the nurses get paid to, it's part of their work that they do. And with the model, it pays the provider so much money to manage these cases. And so the nurses had time to talk to people. And the model worked out actually really well. With inpatient hospitalizations, I know I said I measured about 12 months, but with hospitalizations, when we looked at 18 months post is when we really seen a difference. And the nurses kind of said with hospitalizations, they said, you're going to have a shift because there's a lot of people who are really sick in our health home, and like their blood sugars aren't well maintained and their blood pressures are really high. And when we got them into the model and they were taking their meds regularly and working through all those barriers, they said what's going to happen is they have pent up demand to have like a knee replacement or a hip replacement or a surgery. And they said, you're going to see hospitalizations go up a little bit and then they're going to go down. And they were exactly right. And that's exactly what happened. Office visit rates. It was no shock that our office visits actually went up because they were coming in and they were having improved management. And what happens is the rates go up at first and then they do go back down as the management gets better. And now, with this health home model, they were getting people in the same day. And so again, people went to the doctor and said, hey, I'd rather go to the doctor than go sit in an emergency room for 5 hours. Mental health visits, and I also measured immunizations. Mental health visits did go up quite a bit. We did find in order for people to be in this health home, they had to have a mental health diagnosis. And what we had actually found is when people had done standardized tests on people, once they kind of let down their guard and were very open and honest about what they were really experiencing with mental health issues, they were finding that it was much more severe than what they actually thought. In terms of, they thought when they came in, maybe they were mild, but actually they were moderate. And people didn't want to be forthcoming about how they were truly feeling. And so there again, once the nurse established trust, they were more open with how they were truly feeling. And so they could adjust medications or adjust the counseling, and people actually got to feeling better. And there were more mental health visits. Again, it went up at first and then it went right back down. So and there's a couple of nurse quotes here that talks about if a patient is going through depression or anxiety and they have hypertension, they don't care to treat the hypertension because you have to take care of the mental health issues. With immunizations, I would have thought for sure with immunizations that they would go up in this model, but actually they said people can get immunizations about anywhere here in the United States. So, the flu, influenza, we can go shopping, we can go to our grocery store and get a flu shot. So that actually didn't change. There's really excellent access in the States. And we're getting better with COVID too, by the way. Um, I wanted to highlight social determinants of health. That was a really big thing. We found a lot of issues of people having to deal with other issues, and that was really causing hurdles to getting good access to healthcare. And one of it comes to, one nurse says it goes back to prioritization. That if someone comes in and they're homeless and they need insulin, don't teach them about how to store their insulin. They don't have a place to store it. You have to work on the major issue that's going on at the time. So that was a really good example of how you had to address social determinants of health to really make a change in their care. So conclusions, chronic disease is increasing in the United States, and care is costly and lacks care coordination. And this is something that we're seeing a larger movement on happening here. And my study found 6 really important themes about how the nurse did indeed make a big difference in connecting with the patient. It's that connection that was so important. And they were able to impact the healthcare delivered. And that the nurse-patient connection was making a difference in healthcare. So our role is very important in the healthcare setting. And that, one of the recommendations is that, the nurse and the team need to adapt to change to meet the needs of the patient and not expect the patient to change, because we have to really focus on what's most important to them.